A young patient presents with transient numbness and blurred vision. Is it a migraine, stress, or the first sign of an elusive lifelong neurological condition? Diagnosing multiple sclerosis is one of the great challenges in clinical medicine. Today, we're going to build that case together. Welcome to Harrison Simplified. There isn't that single definitive pathognomonic test we often wish for, making our clinical acumen absolutely paramount. When we talk about clinically definite MS, we're fundamentally looking to establish two critical principles. First, we need to demonstrate dissemination in space, or DIS. This means objective evidence of lesions found in at least two distinct anatomical locations within the central nervous system's white matter. Think of it as scattered damage across different neural territories. Second, and equally important, is dissemination in time, or DIT. This principle requires evidence that these lesions or clinical attacks have occurred at different points in time. It speaks to the episodic or progressive nature of the disease. For the initial clinical presentation, we typically look for at least two distinct clinical attacks, such as visual blurring, numbness or tingling, or motor weakness. Now, let's define what constitutes a clinical attack within this framework. Each attack must persist for more than 24 hours, and critically, for them to be considered separate events, these attacks must be separated by at least 30 days. This temporal separation is key to establishing DIT clinically. While the diagnosis is clinical, paraclinical support, particularly from MRI, is incredibly powerful and often indispensable, especially when clinical criteria aren't fully met. MRI can provide objective evidence to support our diagnosis. For example, if we need to demonstrate a second lesion to fulfill DIS, a new lesion found on MRI can serve as a substitute for a second clinical sign. Similarly, MRI can elegantly establish dissemination in time. This can be achieved in two ways, either by identifying a new focal T2 or gadolinium-enhancing lesion on a follow-up scan, or, more conveniently, by the simultaneous presence of both gadolinium-enhancing, that is, active, acute lesions, and non-enhancing, which are older, chronic lesions, on a single baseline MRI. This latter finding is a powerful shortcut to demonstrating DIT without waiting for a follow-up scan or another clinical attack. It's crucial to remember that not all MS follows the relapsing-remitting pattern. Primary progressive MS, or PPMS, is a distinct clinical course with its own specific diagnostic criteria. Unlike relapsing forms, PPMS is characterized by a progressive disease course for at least 6 months, notably without distinct relapses. In addition to this clinical progression, diagnosis of PPMS requires evidence of intrathecal inflammation. This is typically confirmed through cerebrospinal fluid or CSF analysis, revealing oligoclonal bands or an elevated IgG index. We'll delve deeper into CSF analysis shortly. The diagnostic framework that unifies much of our current understanding is the McDonald Criteria. Its core principle, as we've already discussed, hinges on objectively demonstrating both dissemination in time, DIT, and dissemination in space, DIS, of CNS lesions. Let's break down the McDonald criteria further, starting with dissemination in space. This is typically shown by evidence of lesions in at least 2 of 4 MS-typical locations. These highly characteristic regions include the periventricular area, juxtacortical regions, infratentorial areas, and the spinal cord. Finding lesions in multiple of these locations strongly supports the spatial dissemination characteristic of MS. Dissemination in time, as previously mentioned, is evidence that lesions have occurred at different points in time. This can be shown either by the appearance of new lesions on a follow-up MRI or by the simultaneous presence of both enhancing, that is, active, and non-enhancing, older lesions on a single baseline MRI. This latter finding is a powerful shortcut to demonstrating DIT without waiting for a follow-up scan or another clinical attack. Now let's walk through the McDonald Criteria scenarios, which guide our diagnostic approach based on clinical and MRI findings. Scenario 1. If a patient presents with 2 or more clinical attacks and 2 or more lesions, MS is considered clinically established. In this clear-cut situation, no additional data or further MRI is typically needed for diagnosis. The clinical presentation and objective evidence already fulfill DIS and DIT. Moving to Scenario 2. Here, we have 2 or more clinical attacks, but only 1 lesion identified. In this case, our primary requirement is to demonstrate dissemination in space. How do we achieve this? We can use MRI to find at least 1 T2 lesion in 2 or more of those 4 characteristic CNS regions we just discussed. Alternatively, we can rely on clinical progression, waiting for another clinical attack that implicates a different CNS site, thereby demonstrating new lesion activity in a different location. Scenario 3. This involves 1 clinical attack, but 2 or more lesions already present. Here, the requirement shifts to demonstrating dissemination in time. MRI again offers efficient pathways. We can identify simultaneous asymptomatic gadolinium-enhancing and non-enhancing lesions on a single scan, or we can perform a follow-up MRI to detect a new T2 or gadolinium-enhancing lesion. If MRI doesn't immediately provide DIT in Scenario 3, we might need to wait for a second clinical attack to establish dissemination in time. This highlights the interplay between clinical and radiological evidence. Finally, Scenario 4. This is the most challenging, presenting with only 1 attack and 1 lesion, often referred to as a clinically isolated syndrome, or CIS. In this situation, we must demonstrate both dissemination in space and dissemination in time, utilizing the comprehensive methods we've just described for each. Beyond simply counting lesions, there are specific, named MRI signs that significantly increase our diagnostic confidence in MS. One such classic sign is Dawson's fingers. These are lesions typically oriented perpendicular to the ventricles, a highly characteristic finding. Another increasingly recognized sign is the central vein sign. This is a specific finding on T2 sequences where a small vein is visible within a demyelinating plaque, a feature highly suggestive of MS pathology. And then we have black holes. These are lesions that appear bright or hyperintense on T2 weighted images, but critically appear dark or hypointense on T1 weighted images. These black holes are particularly ominous because they represent areas of irreversible demyelination and axon loss. Their presence is a strong indicator of permanent tissue damage and often correlates with irreversible disability. Moving from imaging to biomarkers, cerebral spinal fluid or CSF analysis holds significant diagnostic value in MS. The hallmark finding present in over 90% of patients with definite MS is the presence of oligoclonal bands, or OCBs. These are defined as 2 or more discrete IgG bands found specifically in the CSF but not in the serum, indicating intrathecal synthesis of antibodies. Other key CSF findings can include an elevated CSF IgG index. This is a calculated ratio comparing IgG to albumin in the CSF versus serum, another indicator of local antibody production. We might also see a mild mononuclear pleocytosis, meaning an increase in cell count, typically greater than 5 cells per microliter. This occurs in about 25% of cases, often in younger patients with relapsing forms. Generally, total CSF protein is typically normal or only mildly elevated NMS. Now, it's crucial to know the red flags in CSF analysis. These are findings that should make us strongly suspect an alternative diagnosis. For example, a pleocytosis greater than 75 cells per microliter, the presence of polymorph nuclear leukocytes, or a protein concentration above 1 gram per liter are all atypical and warrant further investigation for an MS mimic.
Finally, let's consider evoked potentials, or EPs, as a diagnostic tool. EPs assess the functional integrity of specific neural pathways by measuring their electrical activity in response to sensory or motor stimuli. We have afferent or sensory EPs, such as visual evoked potentials, VEP, for the optic pathways, auditory evoked potentials, AEP, and somatosensory evoked potentials, SSEP. We also have efferent or motor EPs, known as motor evoked potentials, MEP. EP abnormalities are quite prevalent, found in 80 to 90% of MS patients. However, a critical limitation of EPs is that their findings are not specific to MS. While they clearly indicate pathway dysfunction, they cannot pinpoint the exact cause. When interpreting EP results, the hallmark of demyelination, which is central to MS, is a marked delay in latency. This means the electrical signal takes significantly longer than normal to travel from the point of stimulation to the brain, strongly suggesting demyelination along that pathway. Given the wide range of neurological symptoms MS can present, we must always consider the differential diagnosis, the dreaded MS mimics. These are conditions that can present very similarly to MS, and it's our job to distinguish them. Other CNS demyelinating disorders, often considered MS spectrum disorders, include neuromyelitis optica, NMO, MOG antibody disease, MOGAD, and GFAP astrocytopathy. A key clinical pearl here is to suspect these conditions in cases of bilateral or severe optic neuritis or particularly severe transverse myelitis, as these presentations are more typical of NMO or MOGAD than classical MS. We also encounter monophasic or post-infectious demyelinating conditions such as acute disseminated encephalomyelitis or ADEM. Beyond demyelination, a host of systemic diseases can mimic MS. These include autoimmune conditions like neurosarcoidosis and Sjogren's syndrome. Infectious etiologies must also be ruled out, such as syphilis and Lyme disease. And finally, neoplastic or vascular conditions like CNS lymphoma and various forms of vasculitis can also present with multifocal CNS lesions and symptoms that might initially suggest MS. And that's our deep dive into the diagnosis of MS, Simplified. If you found this video valuable, please take a moment to hit the like button and subscribe to Harrison Simplified for more high-yield content. Thanks for being part of our community, and we'll see you in the next video.